Welcome to the Home Health Minute, your monthly podcast brought to you by the Home Health section of the American Physical Therapy Association. Hosted by Troy Mead. All right, hello. Today we're joined with three special guests to talk about PDGM and the upcoming webinar from the American Physical Therapy Association. I'm joined by Ellen, Carol, and Bud. If you all could just introduce yourselves a little bit for us. Ellen, you can go ahead and start if you don't mind.
Sure. My name is Ellen Strunk. I'm a physical therapist, live in Alabama, and I work as a consultant with many therapy providers who do provide services in skilled nursing and outpatient and home health.
Hi, I'm Carol Zehnacker. I'm the chair for the Home Health section for the Government Affairs Committee, and I also am a physical therapist, and I am on contract to a home health agency.
And I'm Bud Langham. I'm a physical therapist, and I'm the Chief Clinical Officer for Encompass Health, specifically the home health and hospice divisions of Encompass Health, and really glad to be here, Troy. Thank you.
Well, thank you for joining me. Thank all of you for joining me. I really appreciate you coming on and sharing some of your knowledge around this subject. You know, there's a lot of changes in healthcare, and everywhere you go, whether it's PDGM, PDPM, which sounds exactly the same. Any setting you go into, there's going to be a lot of changes coming up in healthcare, especially for for everybody, even the physical therapists. So, with all these big changes, there's a lot of confusion around what PDGM is and what that means for the therapists out there. Ellen, can you explain a little bit about what it is and what it means?
Sure. I would agree, Troy, there's a whole lot of confusion, and especially with skilled nursing facilities getting the patient-driven payment model in October of this year, followed very closely with the home health agencies getting the patient-driven grouper model beginning on January 1st, 2020. So the primary difference is, we are aware that the current payment model is determined or influenced by the number of therapy visits delivered over a 60-day episode. Essentially, as the number of therapy visits increases, then the payment to the home health agency also increases. But PDGM is a new payment model that relies more heavily on clinical characteristics and other kinds of patient information. It uses that information to place home health periods of care into payment categories, and it totally eliminates the use of therapy service thresholds. So as I mentioned, it will take effect on January 20th, and one of the other big things about this one is it will change the unit of home health payment from a 60-day episode to a 30-day episode. So the PDGM is essentially made up of 5 main case mix variables. You've got your admission source, timing of the referral or the start of care, the clinical grouping, the functional impairment level, and a comorbidity adjustment. So the reason that they decided to pay in 30-day periods instead of 60-day is that they determined that most of the episodes of care are complete in a 30-day period. So it is going to be a little bit of a change because your certification period and your OASIS period still remains at 60 days. It's just that you're getting paid in 30-day increments. A couple of other big changes are that if you get a referral from an institution like a hospital or a skilled nursing facility or an IRF or an LTAC, then it pays differently than if you get a referral from a physician's office in your community. It also changes what is considered an early period versus a later period. So today we have the first and second episodes of care counting as the early period. Under PDGM, we only have the first episode. And I guess I should say the first claim period because, again, the first 30 days is going to be counted as early versus the later one. The next thing is the institutional versus the community. So community would be defined as if they don't have any acute or post-acute care in the 14 days prior to the home health admission. Then we've got the clinical groups, and they're intended to reflect the primary reason for home health services. So there are going to be 12 groups used, The first two actually have the term rehabilitation in their name. So musculoskeletal rehab and neurostroke rehab. And these were designed because, again, the idea was that the rehab is the main reason for the home health encounter. Now, that doesn't mean that the other categories won't have therapy delivered in them. The other categories are wounds, non-surgical wound care, complex nursing interventions, behavioral health, and then medication management, teaching, and assessment. And so this is one area where therapy is going to really have to be advocates with their patients and with their agencies that they work with, because we certainly don't want anybody to get the idea that just because they're in one of these categories that doesn't have rehab in the name, that it means they can't have any therapy. The functional impairment levels also are different. They're defined as in low, medium, and high for each of the groups. And the interesting thing is that we have two new items added to this functional score. One of them is M1800 grooming, and the other is M1033 risk for hospitalization. The last piece, or the last piece that determines, what you might get paid, is the comorbidity adjustment. And your 30-day period might receive no comorbidity adjustment, or a low one, or a high one, just kind of depending on how many comorbidities you have. And there's a broad clinical category list with things like skin disease, gastrointestinal disease, neurological conditions, respiratory disease, and the list is fairly extensive. So again, you could have a low or medium or no comorbidity adjustment. So the result is that we have 432 different PDGM payment groups now. And again, if you have a low utilization payment adjustment, that could be anywhere between 2 and 6 visits in a 30-day period. So there's a different LUPA assignment for each of the categories, which again will make care planning and collaboration that much more important.
Wow, that sounds that's a lot of information, and sounds like a lot of change. And with any kind of change, there's always a lot of anxiety and a lot of misinformation sometimes that comes along with that. But have you heard of any kind of misinformation out there that's around PDGM that's swirling around right now?
Yeah, it's a really good question. I think anytime there is a significant change like this, or some of the ones that we've had in the past when we had therapy thresholds added, there's always going to be some misinformation, and there are going to be folks who don't fully understand. They haven't taken the time to go through and do their homework and understand how the model works, and so they take shortcuts. And sometimes those shortcuts turn into really bad messages. Just for an example, years ago when we had the 10-visit thresholds for rehabilitation, it was very common for agencies and for leaders in those agencies to say, we don't get paid for rehab unless we do 10 visits. Now, that wasn't really accurate. There was an additional incremental reimbursement after you did 10 visits. But to say we don't get paid for rehab unless was not accurate. And I'm starting to hear, Troy, some of those kind of whispers again around PDGM. And I'm not quite sure what's informing these folks around the message of 10 visits again for rehabilitation, or I've also heard you don't get paid for rehabilitation again. And that's just not factually correct. This model is a patient-centric model, like Ellen said. And so we get paid, or we will be paid, based upon those patient-specific circumstances. And so I think messaging and making sure that when we hear these myths or rumors or whispers that are inaccurate, that as professionals, we stand up and challenge those. I think it's really, really important in this model and PDPM and in others, as change continues to come, that physical therapists are seen as resources for understanding this legislation and regulatory change and being able to correctly message it in a professional way.
Well, with a lot of the information out there, with the misinformation, there's those people like you all who are out there trying to get out the correct information. And I think we're all thankful for you all to be those people to do that and to be the ones that fight to try to mold the legislation to to help benefit everybody, the patients, the therapists, and everybody else involved. But there's also others too, like Susan Collins. Carol, do you have a little bit more information about that?
Sure. I'd like to sort of just give a little history about, the importance of advocacy, especially with the formation of PDGM. When HHGM, the Home Health Groupings Model, first came out, there was a lot of angst, but we were able to, by submitting comments and also influencing our legislators, to get some things changes. We actually got the case mix changed from 144 to 432, which was significant. We increased the comorbidities to none, to a comorbidity that was the three comorbidities, which was none, and then low, and then high. So, we have been able to influence not only the legislators with advocacy programs, but we also have been able to influence CMS with our comments. So one of our champion legislators is Susan Collins. She's from Maine, and she has gathered together with Debbie Stabenow from Michigan, John Kennedy from Arkansas, and Bill Cassidy from Louisiana, and Rand Paul from Kentucky, to have a bipartisan bill that is now Senate Bill 433. And what it will do is it will help to achieve budget neutrality over the period from 2020 to 2029. It will prohibit any pre-change rate reductions based on assumptions and require behavioral adjustments based on real, actual changes in provider behavior that reflect provider behavioral changes in response to the new payment module rather than changes in the patient population. It would also permit a phase-in of rate adjustments up and down when an annual adjustment would be greater than 2%. And so again, we are able to maybe quell some angst that people have about maybe the home health agencies receiving great reductions, over maybe $1 billion reductions in the home health payments in 2020. So again, advocacy is very important. I know that APTA will be putting out Take Action, and we would encourage people to go to the APTA website. We will talk further again and have some slides in our actual Q&A section of the webinar.
So I know there's a plan for more information around PDGM from the APTA and the home health section. Can someone speak to what that plan is coming up?
Sure, I'd love to, Troy. This is Ellen. The APTA is aware that there is so much change going on as in this post-acute care world that consists of the inpatient rehab facilities, home health agencies, and skilled nursing facilities. As we mentioned earlier, the PDPM is going to be going into the skilled nursing facilities, and PDGM is probably the biggest change home health has seen since 1999 when PPS was first implemented. So there's going to be a lot of, as Bud alluded to, as you've alluded to, concerns in the physical therapy community. But I think one of the things that we can do for ourselves is, again, talk to our employers, talk to our colleagues about the value of physical therapy. And so over the next 9 months, that's what the association and the sections are going to really be doing, is trying to put together informational webinars, podcasts, resources, tools that can help therapists feel like they are engaged in the process, that they are empowered with information, that they can go back to their employers, to their agencies, to their facilities, and say, look, we can bring a value to these patients. Just because these systems are going into place doesn't mean patients are suddenly not going to need physical therapy. The same patient that needs physical therapy today is going to need physical therapy next year. So we have to be advocates for our patients and alleviate the concerns of, agencies or providers about what it is that we can do. We need to remind them that there's still there's still a lot of quality metrics out there that are being measured. Today, home health agencies, they are measured based upon their performance on several metrics, like rehospitalization, ability to walk, We've got the impact measures about health-acquired infections. There are all kinds of quality measures, and physical therapy and mobility and keeping patients active plays a large role in that. So that's what the association and the sections are going to be working towards over the next 9 to 12 months, is how do we support therapists during these changes.
And I'd like to also add that Ken Miller, the chair of the practice committee for the home health section, will be developing a course to further emphasize the functional limitations and how to apply them. So thank you very much, Ken, for all that you are doing to educate our members, and they can now be aware of what is happening. So I'd just like to remind everybody that, yes, we are going to do a webinar on PDGM, and we're doing it in conjunction with the APTA National. We're doing it on February the 19th, and it should be out on the February the 21st. We are also going to have a Q&A live on Tuesday at 2 o'clock on March the 5th, and then the Wednesday evening following at 7 o'clock for another Q&A, March 6th again. So they're back to back, the 5th and 6th. They're there for people that can get off, that can have time. But then again, if you are still not have patience or whatever, there will be a Q&A at 7 o'clock on Wednesday the 6th. So it is readily available for you at different times, and hopefully that you can come and join us and hear more about PDGM and hear what maybe concerns that you have. We can address them.
Well, with all the changes, there's definitely going to be some anxiety, but there's a lot of bright spots and a lot of positives coming out, especially with those who are out there to kind of, work towards, making this the best it can be. And those out there listening that, want to learn more, there's more information out there. So I encourage you to get out there and attend these webinars, attend these podcasts of mine. You can listen to other ones other than this one. I promise I won't get mad. And just get out there, learn, and speak up for yourselves, speak up for your patients. All right, is there anything y'all wanted to add?
No, I think Bud kind of said it. The only thing that kind of as Bud said, is you shouldn't just read one thing and be convinced it's the truth, right? That if something doesn't sound right, keep searching for information, and don't just go to one source, but really, between CMS and FDA, hopefully they'll get the right answers.
Okay.
Yeah, and we've created we try to create a culture at our company where anybody can challenge anyone in leadership at any point in time. So it's a safe place for anybody in any of our locations around the country to email me and say, Bud, will you send me the document supporting what you said about PDGM and those clinical groups? And if I'm a leader doing the right thing, then that should be no problem. If I make a statement about, CMS is only now paying for 10 therapy visits again, I should be able to support that. If I'm going to put that forward as a fact, then I should be able to support it. In that case, I couldn't. But I think it's really important for people to be comfortable, all therapists and therapist assistants, to be comfortable challenging information that they're just not sure about, and then being a professional and going and finding that information on your own as well. CMS has email inboxes that will answer your questions about PDGM. They're good people. They want to educate. They want to help. They want to make sure that there aren't these bad myths that come around. And so I just can't say enough how everyone has to question what they hear and ask for the source.
I'd like to thank Ellen and Carol and Bud for your time, and I appreciate everything you all do.
Thank you very much.
Thank you.
Thank you for listening to the Home Health Minute, the podcast from the Home Health section of the American Physical Therapy Association. Check out our website at www.homehealthsection.org. There you can find links to this episode, tons of helpful resources for your practice, and how to connect with us on social media. Thanks for joining us, and we'll see you next time.